The patient initially receives a single-dose interscaling block. If the patient is able, they self-position in the beach chair position while still awake to ensure proper comfort and positioning. A foam ramp pillow is placed underneath the legs. General anesthesia is then commenced with laryngeal mask anesthesia, as muscle paralysis is not needed. Proper neutral head positioning is reconfirmed. At this point, it is important to confirm that the backboard is pushed as far to the contralateral side as possible to ensure adequate exposure of the operative field. The operative field is then prepped and widely draped as shown. An exam under anesthesia is performed. A posterior stress test at 90 degrees of flexion is performed, demonstrating posterior subluxation. The shoulder is then reduced with a gentle anteriorly directed force applied to the humeral head. An oblique 4 to 5 cm vertical incision is made, centered over the glenohumeral joint and extended distally and laterally in line with the deltoid. Dissection is carried down through subcutaneous tissue to the level of the deltoid fascia. The fascia is split in line with the deltoid raphe between the posterior and middle thirds of the deltoid. A Colbell retractor is inserted into the division of the posterior middle thirds of the deltoid, retracting the deltoid. The posterior rotator cuff is identified deep to the divided deltoid, and a split is made as shown here in line with the fibers of the infraspinatus, exposing the posterior glenohumeral joint. A rasp and/or burr are used to decorticate the bare area of the humeral head, just medial to the posterior rotator cuff insertion. This serves to improve graft healing. Attention is then directed towards the preparation of the posterior glenoid. In a similar fashion to the humeral head, a rasp and/or burr are used to decorticate the area just medial to the posterior labrum on the posterior aspect of the glenoid. Once the glenoid has been decorticated, 3 1.8 mm knotless fiber tack anchors are placed just medial to the posterior labrum at the superior, middle, and inferior aspect of the posterior glenoid. The sutures from the anchors are then brought to the proposed insertion area on the humerus, just medial to the posterior cuff insertion, and either measured with a commercially available suture measuring instrument or measured with a ruler. This is done with the arm in a neutral position of abduction and rotation. Measurements are made from the glenoid to the humerus at both the superior and inferior aspect of the planned graft, as well as the vertical height of the graft on each side. Attention is then turned to graft preparation. After the graft has been cut to the proper size, 2 fiber loop sutures are passed through the lateral side of the allograft. These will be about 2 mm from the edges to avoid pulling through the edge of the graft. The medial side of the graft is then marked according to the measurements of the locations of the fiber tack suture anchors on the posterior glenoid. The fiber tack repair sutures from each anchor are then inserted through their designated locations on the medial side of the graft as a horizontal mattress using a suture passer or a needle as shown in this video. After each repair suture is placed, then the shuttle sutures from the corresponding anchors are used to pull the repair suture back through the knotless mechanism of the anchor. This shuttles the medial aspect of the graft into place about the posterior glenoid. Once the graft is secured onto the glenoid, then the lateral graft luggage tag stitches are pulled taut and placed against the planned insertion site on the humerus. It is important to note that at this point, if further tension is desired, the luggage tag sutures can be removed and the graft can be carefully shortened in the horizontal plane, and then the luggage tag sutures can be replaced. Once appropriate graft tension is confirmed, the luggage tag sutures are then loaded into a 3.5 mm push lock anchor and inserted into the superior and inferior aspects of the bare space on the humeral head, creating the construct shown. The final construct is inspected. The dermal allograft is now positioned in place under slight tension with 3 medial points of fixation along the posterior medial glenoid and 2 points of fixation on the humeral head. A posterior stress test is then performed with the shoulder at 90 degrees of flexion, demonstrating restraint from the posterior subluxation as shown in the video here.